Thank you, Manos, for your invitation. I mean, it's very huge for me to be here and to present a modification of the arthroscopic Latarjet with the screw, because thank you. Oops. Thank you. The arthroscopic Latarjet was described in first by my partner Laura Foss in 2005. But the problem is, and Tom demonstrated that very well, it's a very demanding technique with a free end step of the technique, and sometimes it's difficult to reproduce exactly the same technique for every patient, and you can have some problem with the screw positioning. And Ovelius demonstrated a very long time ago, it was very bad if you have a big angulation with the screw regarding the glenoid neck, because the first risk is a malunion. The second risk is a contact between the screw head and the humeral head, and you have very quickly arthritis after that. I use the big chair position with the arm traction with 2 kilograms to a very poor traction. I can mobilize the arm as I want. Regarding the portal, I use 2 posterior portal, because one portal for the guide, for the scope, and the second portal is for the second part of the posterior jig. And anteriorly, you have 2 big portals, one to prepare the coracoid process and one portal to screw the coracoid process onto the bone, and one portal for the scope and 2 portals for the instrument to prepare everything. And the first step, sorry. Yes. The first step is exploration, and it's very important because sometimes you find very big defect of the capsule, and for me it's the best indication of the Latarjet, because you have bone loss on capsule insufficiency, and you have no option for bone block or Bankart combined with a Bankart repair, or Brislow technique with Bankart repair. You need to have a triple effect as Didier Pat described in 1980. And it's very important to check, and to check also the cuff and the labrum and everything into the joint to be sure you can repair all damage of the joint. After, it's the time to prepare the coracoid process. Is very important to do that, but the problem is you need to use radiofrequency probe to prepare the coracoid process. Certainly you burn the coracoid process too much, and you can have some problem with the bone resorption after. You see the coracoid process preparation here. And the most important step is the subscapularis split. I use the switching stick from back to front. I don't cut the coracoid process in first, and I push my switching stick lateral to the conjoint tendon to be safe and to don't damage the nerve, because Tom showed us it's a big problem with arthroscopic Latarjet. You can damage a nerve, and it's very important to protect the nerve as well. And after doing this manipulation of the switching stick, you must be very lateral to stay lateral to the conjoint tendon with the stick. And after that, I use the posterior guide. This idea is coming from Ettore Taverna, because I remember the CSEC meeting in Lyon in 2011. And it's the first time you, Ettore, show us the posterior guide to drill the glenoid neck. And I think it's the best way for the arthroscopic management of the coracoid process. And I use it like this, and I develop with Artrex company another guide with the two barrels to create two tunnels into the glenoid neck to be safe, and to be sure the tunnel is very, very close to the parallel of the glenoid surface. You can help me because I cannot change the slide. You can, okay. After, with this guide, I create two tunnels into the glenoid neck, and into the two tunnels, I push two K wires, and I pass through the subscapularis split with the tube, and I push a front of the conjoint tendon, the two K wires. It doesn't work. And the two K wires stay front of the conjoint tendon. And after that, I prepare the inferior surface of the coracoid process as flat as possible. And especially with the rasp is definitively easier to do. And after, I connect the inferior screw, inferior hole of the coracoid process to the inferior K wire, and I move, I start to screw the coracoid process with the Artrex screw 4.5 with the Di Giacomo plate, because you improve the compression of the coracoid process onto the glenoid neck. It works. And with the Di Giacomo plate, I have better compression of the coracoid process onto the glenoid neck. I am sure the orientation of the screw is good. And there is a video. You cannot show the video. Yes, this one, please. Okay, you see the preparation of the neck, glenoid neck with a rasp. It's very flat, and you can expect a good contact with the bone between glenoid neck and coracoid process. You see the switching stick laterally to the conjoint tendon. After that, you can start with for the subscapularis split. I make the split a little bit lower to the switching stick to be in the middle of between the middle part and the inferior part of the subscapularis. And you find the glenoid neck preparation. It's good. It's good. And after, you can introduce your guide from back to front, like this, and you see the positioning of the guide. You can select the position from high to low to be sure at a good level regarding the guide, and you can drill superiorly and inferiorly after. And after you put the two K-wires, you see the superior K-wires, they go outside, and with the rasp you can prepare very well the inferior surface of the coracoid process. And after, you can cut it. It's very flat, and it's more efficient than the burr, because with the burr you have some wave onto the bone, and the contact of the two pieces of bone is not good enough. And after you cut the coracoid process, you connect the coracoid process with the anterior guide. You see the two K-wire in the position, and after you connect the inferior K-wire with the inferior hole of the coracoid, and you see you can finish to the preparation of the coracoid, and after you can screw with the Di Giacomo plate, and you connect the screw with the glenoid neck, and you finish the screwing. You can elevate the upper part of the subscapularis with the C-elastic drain, like described by the Chinese surgeon. And after you finish, and you compress with the screw, and you have a good compression. And you can check by the posterior part, and sometimes you have some proeminence of the bone, and from anterior you can finish the positioning. Okay, it's done. You decrease the risk of suprascapular nerve damage, and you can make some additional step, and you see the final aspect, and you see the direction of the screw, and it's typically more reproducible than a free end step of the other technique from Arthroscopic Latarjet. Thank you so much for your attention.